We have a 65-year-old female she underwent laparoscopic cholecystectomy for a gallstone disease, symptomatic gallstone disease, and on histopathology it was found to be a moderately differentiated adenocarcinoma and staged as PT2N1.
को निकालना बहुत ज़रूरी है क्योंकि अभी स्टेज में कैंसर क्योरेबल है, ट्रीटेबल है, मतलब उसका इलाज हो सकता है, बाद में फिर वो फैलेगा, फिर मुश्किल होती है। और सबसे ज़्यादा मुश्किल ये होती है कि जो लिम्फ नोड्स होते हैं वो जो जिस रास्ते से बाइल आता है उसको ब्लॉक कर देते हैं, फिर पीलिया हो जाता है। तो पीलिया होता है तो फिर वो रिसेक्टेबल नहीं रहता है। हाँ, इसलिए क्योंकि समय पे मिल जाना जो है वो फ़ायदे की बात होती है। ठीक है, what could have been done on the table if there was a suspicion, the frozen should be sent, and also you can split open and see in these cases, and the bile can be sent separately. So whenever there is a suspicious laparoscopic cholecystectomy, the gallbladder looks suspicious, it is always good to open it up because you can detect it then on the table and take a call. That's an advantage because in one surgery you can do both. We don't need to do open all the time. We can still go for laparoscopic, radical, completion radical cholecystectomy. That's it. So that's the plan for this case. Is that clear? Any questions?
Sir, one question is, if the surgeon did not consider the possibility of a tumor and he has removed the specimen not in an endobag, he has removed it from a post.
That's a brilliant question. Therefore, we have to trace back the surgery. We have to also confirm from the previous surgeon whether there was any spillage. We also have to confirm whether it was retrieved in a bag or not, which ideally it should be. And that is why I'm saying, even if you don't get, if you're getting no information, the ports should be excised. And if you don't get any information from the previous surgeon, then we need to trace it with a lot of effort. Is that clear? Well, that question is important. We need to assess that carefully. The PET scan and node positive disease. No metastasis to the liver, etc. No ascitic fluid, so we are fine. Can take up for completion. Now, when you talk about completion now, she's asking a question now. Would she require chemo? What is the usual recommendation for chemo? Node positive disease would generally require it. So, yeah. So, no, it will be required. So we will. That's why my answer was let us get those nodes anatomically, pathologically dissected and seen, and then we can take a call. But patient would require some systemic therapy. It's a very aggressive tumor, so you should not delay it any further. Now these are the ports. I think this is one, and we'll have to excise the ports. No, that's why it's important to excise the ports. This is the epigastric port, na? So epigastric port, doubtful area, and that is where Agni's question was very valid. Now you need to make sure. This is here, and we need to adequately excise the ports, send them separately, got the histopathology report for that also. But in any case, you don't have an option. You have to believe whatever is written by the previous surgeon, and we have to we have to approach it that same.